Okay, before we get started, Maggie has reminded me that I forgot one last announcement, which is that we're a great and close community here, and several people in the room may have either been reviewers or were, if you were interviewed as part of our process. We just ask that you, if you were an interviewee, to keep that confidential, as we are trying to protect the confidentiality of our of both the countries we visited and the organizations that we interviewed. And if you were a viewer, to just try and speak to the report as it is today and as it was released, and not to the report as it was when you first received it and reviewed it, though we thank you again for your feedback. So with that, I will turn to Nina and she can start us off.
Just checking. Sounds good? Yeah. So good afternoon, everybody. And I, of course, am going to lead off by thanking the IOM for this really impressive and comprehensive report. We really appreciate all the work that went into it. And I also want to start off by recognizing PEPFAR's implementing agencies, USAID, CDC, NIH, the Peace Corps, DOD, and others. We could absolutely not put this program on the ground without the work of those agencies, and I think it's important to note that, and also our implementing partners who are the heart and soul of PEPFAR's response. So I just want to start there. And then I just want to say we're pleased that the committee found so much of PEPFAR's work on HIV prevention to be good. We agree with you. We're pleased but not satisfied with what we've accomplished. And in the last decade, since PEPFAR was put on the ground, UNAIDS has also noted some pretty impressive improvements in the rate of new infections. Overall, about a 50% reduction in the rate of new infections in the countries hardest hit, and some countries like Malawi showing as much as a 73% reduction in infections. And that makes us hopeful. It doesn't make us complacent, but we recognize that there's a lot of work left to do, and that HIV prevention is in some ways an especially challenging arena to work in. In the recent period, PEPFAR has shifted the focus of our prevention programs to reflect much of the advice in this report. And the prevention guidance from 2011, I think, really speaks to that. We are encouraging countries to have a much more epidemiologically focused response. We built on UNAIDS, know your epidemic, know your response, and we added two more knows, know your context and know your costs. And the other piece that has really shifted our approach to prevention is the evidence that treatment plays such a powerful role in averting new infections, adherent treatment. And so now we don't see that our treatment platform is distinct from our prevention platform, right? Those work together synergistically to prevent new infections. And that has really, I think, caused a real shift in the way we're thinking about prevention going forward. We're also turning away from an approach that sort of categorizes biomedical, behavioral, and structural interventions as three distinct categories with three distinct programs. Instead, we're increasingly seeing these as critical components of all prevention programs, right? So one example might be voluntary medical male circumcision, a program that we're just getting off the ground in the last few years. It centers around a very effective biomedical intervention of circumcision. But in order to get those programs off the ground, we had to do major structural interventions. We had to work with countries on policies. We had to strengthen health systems. We had to train lots of surgeons. And we also had major behavioral components that we had to work on and that we continue to work on, right, around demand creation, around preparing communities, and also around increasingly communicating not just with men, but with their partners and their mothers, and to really build a whole community understanding. So that, I think, is the model going forward. It's not one or the other. It's the understanding that these are all components of an effective intervention, and we need to continue to learn how to do that. The PMTCT platform is another very important place to do that. We're just really, I think, starting now to think about how do we build strong linkages between our PMTCT and our OVC platforms to help keep mothers and children engaged, and to do the behavioral pieces and the structural pieces around making PMTCT work. And so I'm really interested in engaging in a dialogue, I think we all are, about this. We have a lot to learn about how to do this well, but I think it's the direction that we're headed. We wholeheartedly agree that better measurement and tracking of our prevention portfolio is the next horizon. That was a major recommendation of the report. This involves both improving the quality of indicators and measures that we use and building the capacity of partners to collect and use high quality data. And our particular focus will be on measuring coverage in the next period, knowing the size of specific populations in defined geographic areas so that we can track what proportion of those populations we've reached with a comprehensive prevention package. And that has a number of challenges inherent in it, including having good data to begin with, but that's an iterative process where we work together with our, with country partners to figure out how to increasingly build this data. While we continue to look forward to the development of an accurate and scalable incidence measure, we agree that identifying better proximate indicators of incidence and impact is key. And we really welcome input from the IOM as well as from other stakeholders in the room and in general on this discussion. It's a tough question what those outcome indicators should be. And I think we continue to circle around and look for new data to help give us some confidence that we're choosing the right ones. So those are sort of our high-level points. Dr. Ryan's going to speak a little bit to kind of what we're doing right now, and then if we have time, I'll circle back to what might be next.
Okay, thank you very much. I'm just going to touch briefly, because I want to make sure there's enough time for everyone, on some of the things that we're doing now and just give you an update. So on treatment, as you know, PEPFAR supports over 5 million men, women, and children. For condoms, we have a substantial amount of investment in condom provision and promotion, including female condoms and lubricant. And in fiscal year 2013, we've established a special central fund to cover additional emergency procurements in the cases where there's stockouts and shortages. On the World AIDS Day targets from 2011 that we were to provide 1 billion condoms by World AIDS Day 2013, and in fiscal years 2012 and 2013 alone, we estimate that we'll be above 1 billion condoms. For voluntary male medical circumcision, we are looking at sexual transmission and the impact that it has both for men but also for women and other uncircumcised men at the population level. And we have been, to date, since 2007, circumcised over 2 million men, and we're hoping to get very close to the World AIDS Day target of 4.7 million by the end of this year. Circumcision is one of those things that is exponentially increased, so every year we do twice as much as we've done the years before. For structural interventions, we are working both on our prevention platforms and our OVC platforms to do things like economic strengthening and other types of interventions that help women avoid high-risk behavior and situations. And we've been working through governments, especially through the partnership frameworks, to support the policies and laws that create enabling environments and mitigate harmful behaviors and norms. For HIV testing and counseling, since the inception of PEPFAR, we have provided 190 million HIV testing and counseling encounters. And what we're finding is that knowing serostatus, and especially locating people who are at higher risk of HIV and making sure that they get tested, is a new sort of emphasis, as is making sure that once we reach people with HIV counseling and testing, we link them to treatment and care. In terms of key populations, that's men who have sex with men, people who inject drugs, and sex workers are really our focus. We have really been trying to focus in both concentrated and non-concentrated and generalized epidemics on these populations. And that would be through promoting enabling environments such as supportive laws, regulations, policies, and social norms, as well as to make sure that there are services and antiretroviral treatment available for these populations. We've also looked to try to foster networks, and we have put $2 million into the Robert Carr Civil Society Network, and to try to get countries that have not to date really invested in key populations. We put forth $20 million this year for the Key Population Challenge Fund. So countries had to also invest through their country operational plans, and then we added to it through the Key Population Challenge Funds, and those are about to be awarded. There's some very exciting new programs that will be initiated through that. And then finally, PEPFAR has committed $15 million in the Key Population Implementation Science Fund. And these are studies that will focus on providing the knowledge necessary to implement the most cost-effective services for these populations, and also working with country partners to scale up services for MSM, sex workers, and people who inject drugs. So key populations is one of the key areas in prevention that we've been focusing on. Also a key population, but it has had its own focus on adolescent girls. And as part of GHI, there was a commitment to empower adolescent and pre-adolescent girls by fostering and strengthening their social networks, educational opportunities, and economic assets. We also were investing in a Vulnerable Girls Initiative, and we did formative research at the country level in 3 countries to understand specific sources of risk and resilience for the most vulnerable adolescent girls. And from this data, the Go Girls project was created, which includes interventions for girls, as well as schools, families, and within the community, networks to reduce and promote girls' well-being. So I think at this point I'll turn it over to Nina.
How are we doing for time? Are we all right? Just really quickly about going forward, there's I think 3 areas of the report where we really see ourselves moving to respond or in the same direction. And one is around this issue about data and monitoring and evaluation. So we're going to pilot with a few countries this sort of coverage-based approach, right? Where you really try to home in on some geographic areas, identify the key very high incidence, identify those populations, and track with a denominator your level of coverage. And then there's some broader initiatives around monitoring and evaluation that Paul Bowie will discuss, I believe, during the SI session. I don't want to steal his thunder, but I think that really gets at some of the questions around quality and around monitoring quality and how are we going to do that in the next iteration. And then there were some recommendations around research and innovation. And so I just want to highlight a few things that we're doing there. Around innovation, Caroline just mentioned the Key Populations Challenge Fund, and there's also an Implementation Science Fund, and we really are starting to see these as the ways to motivate innovation at the level of the program, so that really where you're innovating is with in a specific culture and country context, what's going to work there. And then to have the implementation science to really look at the impact of that innovation kind of paired together. And then in terms of research, we do have this significant investment in these combination prevention trials. They're sort of about to get off the ground now. And then the last piece is that in the last few years, we've been piloting this new approach of impact evaluation using bilateral funds. So it's a little technical, but basically encouraging country programs to do rigorous impact evaluation on their programs using COP monies to look at the impact on whatever the right outcome measure is through the program, rather than having to come through a more cumbersome kind of headquarters process. And it's taking a little while to get that off the ground, but we're really optimistic that that's going to increase substantially the amount of really rigorous evidence we have for the impact that our programs are having at that level of activity, rather than trying to look for big generalizable conclusions. So I think I'll stop there, yeah?
Thank you both so much for your comments. I'll just keep moving down the aisle. So if Dorothy, if you want to take a few moments to go next and respond.
Okay, thank you. I'm from FHI 360, the Roads Project, and since 2005, funded by PEPFAR, we've been involved in extending HIV and health services to key populations along an important geographic area, which is the transport corridors and waterways of East, Central, and Southern Africa. I think in listening to the people we work with in the over 60 sites in 9 countries, right now, we are every day faced with the stark realities and complexities of HIV prevention. And I'm really pleased to see from the IOM PEPFAR evaluation report the particular recognition that all 3 biomedical, behavioral, and structural interventions have to work in tandem for what the report refers to a comprehensive and balanced approach. It is true that oftentimes people at elevated risk just the combination of economic disparity, extensive sexual networking, mobility, high levels of substance abuse and gender-based violence, and sometimes a dearth of quality services, will make decisions driven by the circumstances they find themselves in. And that's really true. And I just recall, as I was thinking about this, how a few years ago, a HIV positive woman in one of the sites where we work, the border of a town called Tunduma, which is the border of Tanzania and Zambia, she really couldn't stay on ART because she simply had no bus fare to remain on the program. And because the site where she needed to go was Mbozi District Hospital, which was 25 kilometers away. Thankfully, because of PEPFAR funding, this has since changed, and now ART services are available closer to her at Tunduma Health Center. Also, just thinking about the many sex workers we interact with along the corridors that we work with, where they will hesitate in as far as negotiating for condom use when it's time to pay school fees for their children and time to put food on the table every night. These are just very simple and basic examples of critical structural issues. And so I'm really, really glad that in the IOM report, in my view, I consider that there are 4 tick boxes. And as it were, there is an A, biomedical, there's a B, behavioral, there's a C, structural, and finally there's a D, which to me I believe is the most important box, which I think in my view is all of the above. I think this is a really important contribution against the backdrop of the continuous debate that we see and get involved in around just the weighting of the 3 interventions. So it's really great to hear, Nina and Caroline just talk about that. It's not either one or the other. It's really everything coming together, and that's really critical. Of course, supported by implementation science. And so I couldn't agree more with the need to measure the effectiveness and build the evidence and knowledge base around behavioral and structural interventions, where that is indeed lacking as we look at our programs. There's a lot more that needs to be done, I think, by the public health community towards this end. And I think it's around time that public health could possibly borrow and apply certain measuring techniques that I think in some sectors link investment and behavior outcomes. And I'm particularly thinking about the advertising industry. And for instance, political polling. The advertising industry, I'm right now struggling to get rid of being a Coke buyer. But I imagine that the Coke people know what I need and how to get there. And so, they've basically tracked my behavior. And so I'm thinking that people like that have devised very sophisticated techniques that link budget to sales, which essentially are modalities to understand key factors in shaping behavior. And even just thinking about the pollsters, Kenya just concluded a pretty interesting and significant presidential election. And it was just amazing how political polling predicted voters' behavior vis-a-vis prevailing and diverse circumstances around the country. For me, the question is, can we do that for public health interventions? And particularly where we are faced with the issues around behavior and what people do and how they will respond to messages, how they will respond to issues that are they supposed to make decisions about. Of course, the need for implementation research for HIV prevention, as I just said, cannot be gainsaid. I also look at it from there's also just one last point, the need to identify country-specific key populations, and I think that was referenced in one part of the report. Even though, yes, we are looking at key populations, female sex workers, MSMs, and people who inject drugs, I think every situation and countries will have very specific other vulnerable populations. And it was good to see the report mentioning some of them, clients of sex workers, truckers, mobile men, young women, non-injected drug users, particularly those who are abusing substances other than, like alcohol. And so all in all, I think it's a great report, and it's also great to hear that even just looking at the PEPFAR 2011 guidance that a lot of we are moving in the right direction. And so this report basically validates some of the things that are going on and the road that needs to go on. Thank you.
Thank you so much. Dan, do you want to go next?
Thanks. And I can't see the timekeeper, so let me know if I go over. When Deborah was showing her slides earlier about decreases in HIV incidence, I was struck by what really is an irony of HIV prevention, an unexpected irony that I don't think any of us would have predicted 10 years ago, which is that the greatest progress has been seen in countries with generalized epidemics, and that is the countries with concentrated epidemics, particularly in Eastern Europe and Central Asia, where the rates of HIV are still growing fastest. And reading through the reports, it's clear that the committee and the report writers were actually relatively limited in the insights they could offer about PEPFAR's work with sex workers and drug users. And I think that that says a lot about why we haven't made more progress. For sex workers, PEPFAR's data on spending often remains unhelpfully blended with overall information about the program's work on prevention of sexual transmission. That said, efforts at promoting abstinence or being faithful, which, as noted in the report, still accounts for the majority of those reached by PEPFAR, clearly offers nothing of use to sex workers. The question of the constitutionality of the anti-prostitution pledge will have to be decided by the Supreme Court, which will hear the case this summer, but non-US NGOs will likely remain bound by this confusing, unhelpful, and unscientific requirement. Drug users account for about a third of new infections outside of sub-Saharan Africa, but PEPFAR only began tracking interventions specific to drug users in FY 2010, which was too late to offer much data of use in this analysis. And honestly, to a question this morning about the return of the ban, OGAC squeamishness and uncertainty about congressional response to funding needle and syringe exchange, even when the ban was lifted, meant that very little or no money went for that intervention in the time when it was possible. The IOM reports note correctly that PEPFAR has been critical to progress on methadone in countries like Ukraine and Vietnam. And those are very important developments, although to date those interventions reach a relatively small fraction of injecting drug users in need in those countries, and structural interventions that are increasingly recognized as essential to HIV prevention. And I'm glad to hear that they're being conceptualized as a part of the package, but particularly those structural interventions that increase access to justice and reduce police harassment, detention, and imprisonment are not called out or analyzed specifically in these pages. We talk often about how drug users and sex workers are hard to reach populations. In fact, police in many of the countries where I work seem to have no problem reaching them. We were asked to end with a question for the panelists, so I'll end with a two-part question about how and whether PEPFAR can do more to join its political influence and scientific evidence in HIV prevention. As was mentioned this morning, Congress does currently prohibit support for the purchase of needles and or for groups who do not oppose prostitution. But I do think it's possible, as Deborah mentioned, that PEPFAR could work a lot more closely with other donors to pay for everything but the needles and to make sure that there was some structure, particularly in countries with concentrated epidemics, to ensure a continuum of evidence-based HIV prevention. This is a very strong need, not only in Eastern Europe, but in countries like Kenya and Tanzania, where honestly, I receive calls asking for funding for needles because the country partners don't feel like they have another way of doing that. The funds are not an enormous amount, but we just need to figure out some mechanism to close those loops. A second question also mentioned this morning was about the key role that punitive national approaches play in perpetuating HIV among sex workers, drug users, and MSM. And, you know, the real anxiety that a turn to country ownership may not be so helpful for criminalized groups. So how we can use more effectively negotiations around the partnership frameworks to urge the kinds of reforms that are needed to protect the vulnerable and to scale up the kinds of interventions that will reduce the detention, forced testing, and police harassment that remain really some of the critical barriers in the HIV prevention zone and also in the HIV treatment cascade. Thanks.
Never a good idea to follow Daniel Wolfe. But let me try, and let me also just say, sort of in interest of full disclosure, that I was one of the external reviewers for the IOM evaluation, and I really want to applaud both the IOM, the evaluators, and PEPFAR, because this was a massive undertaking, and I think. As somebody who has to read a lot of unbearably bad English language prose as a professor, that it was admirably clear and well written, and that is something to be thankful for. I'll just make perhaps a couple of comments about the prevention elements of the report, and then one or two of the challenges that others have also raised, but that I think are really sort of what is going to be important going forward. First off, I have to say that I think probably everybody would agree that one of the signal contributions in prevention has been the success in prevention of mother-to-child transmission. And that is for several reasons. One, certainly because it's kind of in the DNA of PEPFAR, and it was there actually before the 2003 program. But in addition to that, this is one of those domains where you have a measurable and a deliverable. And that is so important because I think, unfortunately, and I won't go into detail at this moment, but perhaps when we get to the challenges, that we don't have an equivalent statement akin to, and we prevented 350,000 perinatal infections. And that's so powerful, and it's so tangible. And I think that's the challenge in a way for all the other domains of prevention going forward. The second thing I would say is that, of course, one of the sea changes in this field, as we all know, has been the increasing understanding and now the scientific and clinical trial evidence that treatment is indeed prevention. So when PEPFAR initiated this extraordinary platform and rolled out HIV testing and counseling, building the infrastructure, the laboratory components, getting drugs in country, training providers, all of that was to save lives. It was not perceived necessarily to be a prevention target as such. But nevertheless, now that we've seen this happening, imagine the counterfactual. If we had the results of HPTN 052 and we hadn't built this platform, you know, it's extraordinary to imagine how much worse, first of all, the HIV epidemic would be in the most affected countries. And really, we'll never know now. It's not a question probably that's teasable out. But there's no question that a substantial component of the declines in incidence in these heavily affected populations is indeed the outcome of treatment. And that is a huge success of PEPFAR. And I would say that arguably one of the really, best pieces of evidence we have for that is the recent report from Tanzer, from the KwaZulu-Natal, the Africa Center, which is a demographic population-based analysis. And it really shows that, 40% relatively moderate treatment coverage in a basic nursing-led clinical system actually had measurable reductions in seroincidence. And that, to me, is a profound example of what PEPFAR has been able to do. I think voluntary medical male circumcision is turning out over time, and as we begin to see the population impacts, to be a better intervention even than we thought from the RCTs. That's so encouraging. That is not often what happens in our world, right? That the trials look great and then you implement and you see actually lower efficacy. That's not what we're seeing. We're seeing the power of this as a sustained intervention, and I think as the data gets better and we see more of it, we're going to see that it's protecting women too. And that certainly is a hope and a goal. And I think PEPFAR's investment in voluntary medical male circumcision is a prudent one and one that needs to be supported. Okay, and then, of course, there are the challenges. And I would say first and foremost, in my view, the challenge is all of the domain of the indicators, the assessment, the measurement of the preventive intervention effects. And while everybody here has spoken to, and we all agree that combinations and that doing, biomedical, behavioral, and structural is the way to go, that makes the ascertainment all the harder, right? It's easier to assess the outcome of one kind of intervention. It's very hard to do that when you're saying we're going to do everything. And I think what that means is we're going to need more global measures. My own view is that there are going to be some technical breakthroughs that are going to make this easier, and we're going to have cross-sectional measures of incidence that are going to be implementable at population level. So we're going to be able to look at incidence in the way that we look at prevalence with cross-sectional population-based assessments. And that is going to enormously help us. And we won't ever be able to say that is because we invested in 30% of behavioral and 40% of structural and 15% of circumcision. But nevertheless, we're going to be able to track incidence at population levels, inshallah. But it looks like it's already been validated for clade B in North America, and so I think it's hopeful. But nevertheless, the report is very clear about saying, for example, that the lack of systematically collected information on activities, outputs, and incomes made PEPFAR essentially unable to assess its impact on sexual transmission. I don't think, looking at the global data that we're so worried about that, but looking at ensuring the support for this program going forward, that is something we really need to change. I won't go into the key populations elements except to say that I think that PEPFAR has really been admirable on focusing this. It has really improved the dialogue and the discussion in a number of countries, but I think everybody here knows that country ownership and transition is a real challenge and a real threat for these key populations. And that is something that definitely is going to require the diplomatic engagement that Deborah mentioned this morning, and we can only hope that that is sustained and continues. Thank you.
Thank you very much for having me here today as well. I'm Mike Tolle, and I work with the Baylor International Pediatric AIDS Initiative. It comes from Baylor College of Medicine in Houston, and we operate a network of pediatric centers of excellence across Southern and East Africa and in Romania, a total of 8 centers. The last couple, my family's been in Africa the last 7 years working with Baylor in the field, and the last couple up in Tanzania, where I've been the director of the program, 2 centers, one in Mwanza, one in Mbeya, with about 3,000 kids in direct care, and together the network supervises the care of about 100,000 African children with HIV infection. I just want to, again, thank the committee for a phenomenal report. It's very interesting to read. It was very interesting to read there in the field. These are the kind of things a lot of us have been wondering, what's the impact of all this, and where's the program going in the future? And I encourage, which I've seen a lot of the dissemination, but further dissemination to implementing partners. I'm not sure everybody's seen it, but at country level, there's a lot of interaction between the country teams, the PEPFAR teams, and I should have mentioned the Baylor program in Tanzania is a PEPFAR-funded program. A lot of interaction between the country teams and the implementing partners, and I think this will really help people to know where PEPFAR is going and remove some of the confusion that I think sometimes exists about what the priorities are and why there are these particular priorities. From the perspective of a child's physician in Africa, a couple of areas really stood out to me here in the prevention chapter. Naturally, PMTCT, which I'll come back to in a minute, but also the issues around sexual transmission, which are substantial issues for adolescent populations that programs like ours take care of in Africa, particularly issues around multiple concurrent partnerships, gender-based violence, and a number of the things that were discussed this morning. And it was interesting to see that you also struggle with this challenge of measuring the impact of interventions in this field. And we know it's a critical area. There's a lot of work going on in the area, but sometimes knowing what's actually being achieved is a challenge. And that's something I think that all the implementing partners will look forward to working with PEPFAR on in the future. And I'm really interested to see these new techniques and to be able to put those to work in the field as well. And that brings up the subject of targets, which you touch on in the report quite nicely. And in the area of PMTCT, I think really stands out. There's a statement in the report which is quite true, that we know what works in PMTCT and we know how to eliminate infections in children. And we see in our Western settings that this has been largely achieved, and that the issue in Africa is one of implementation of these interventions. And we would certainly second that in our settings. We have looked at this in a number of our settings, and just recently in Tanzania, where we still see a lot of infected infants. And I think there's a bit of a feeling sometimes in the broader community that we've won the battle on PMTCT because we know what works and we have trial results that are outstanding, but we know in the field there's still a long way to go. We're far from the 80% coverage that's the target, and not even close to that in a lot of settings. And I think we need to keep our eye on those targets and work together on how do we get to levels of coverage in communities, particularly rural areas, but communities in general in countries where the coverage rates are still low. We still see a lot of infected infants, and about 90% of those, as you can imagine, moms had no access to PMTCT. Something I think that also may slip through the cracks a bit is the difference between delivering ART to mom as the outcome of interest and real prevention of infection in an infant. We know in most of our settings where infants are breastfeeding that transmission, you'll see data of 40% of transmissions occur through breastfeeding or what have you, but it's substantial. And that if we're just looking at the delivery of ART to mom, we miss a lot of the transmission that takes place to infants. And many of our settings struggle quite a bit with early infant diagnosis and loss of infants who have received PMTCT interventions from final diagnosis. And that's something I think for implementers to make sure that we're focused on, but also when we evaluate the impact of the programs and to see what real prevention is. For sure, there have been tremendous benefit from PEPFAR. Unbelievable, I think, in the field and people's perception, but we need to make sure we're really tracking prevention in infants all the way through, because we lose a lot of kids to follow up and know that they likely get infected down the road in their infancy and suffer poor outcomes. So keeping a focus on EID. I really like in the report the beginning to bring up child survival and more than just the HIV specific endpoints, if you will, and linking PMTCT, for example, to child survival. I think that's something that fits with the holistic approach that many of us feel like we take in our medical practice in Africa, and encourage that and applaud that in the way we strategize, the way we evaluate, and the way we iterate our programs to keep an eye on ultimate child survival. That's the concept that's behind concepts like monitoring breastfeeding infants and tracking infection all the way through infancy and making sure infected children get on ART and continue on. So following progress in PMTCT impact on child survival, I think is very key and something we should integrate into our entire approach. Another aspect of PMTCT that's talked about in the report that's very important and something that might be nice to discuss today is on the concept of integrating together in a single setting PMTCT, early infant diagnosis, and linkage of infected infants to care and moms to care. We know that moms that, again, mom can be diagnosed positive in pregnancy, receive ARVs, but infant may not be tracked out to final diagnosis. Mom may not be enrolled in subsequent care, and we have issues with mom survival, child survival. This brings up option B plus, which gets a little discussion in the report. It was obviously not something that was in widespread use at the time of the evaluation, but a topic I think that merits some discussion is how to scale up option B plus, particularly given we don't have full scale up of current interventions, and how do we scale up B plus when we're struggling with weak health systems and putting all this together, because we know the potential impact of that, if done successfully, could be quite great. And then the last concept item that comes up in the report and has been discussed a lot today, I know there'll be a separate session later on transition to government, but I think that's an important topic even in a discussion of prevention. This is something that we all recognize in the field needs to happen. There are limitations on resources and how long those can be delivered. I know as providers, we really, it's an area that we feel like we could use some more information on. There's a lot of push at country level to work on transition. Not sure everybody really knows how to do that or what that really means in terms of engaging governments and finding some stepwise transition to programs, and know that all of us, while wanting to see that move forward, I think everybody wants to make sure we don't lose the gains that we've gotten. I think we may forget sometimes how many promises we've made in the field. You know, to make these things happen and really have the outcomes we want to see, a lot of individuals are engaged. Traditional leaders who've made the jump from being a skeptic to an advocate, moms who've faced down stigma and gotten enrolled in care and have their kids enrolled in care, and our country colleagues, you know, who were dealing with this before we got there, and they'll be the ones that take care of it when we're gone. It's a lot of promises, and something that I know all of us want to work together in making sure that we can continue. And I think the more the success of PEPFAR can be disseminated to the general public here, will be quite useful in that. From the ground level view in Africa, the changes have been dramatic, and there's a lot of talk about measures, and it was an outstanding evaluation. But one thing I don't think that got looked at, probably methodologically impossible, or perhaps even some issue with ethical approvals, is talking to beneficiaries themselves. But beneficiaries of the program, if evaluated, would give a very positive review. And things, just the overall sea change that's taken place in Africa, we see in our centers, we used to have many children come into the center and die every day, and we have very few now, to the point that it's a notable event, and one child dying is somewhat remarkable, which is exactly what it should be. It's the way it is. It's the way it is in a system that's functioning, and that's a major change. We struggle now with how to do second line and even third line treatment, but we very rarely bury an infant who's died of PCP. These things have in large part to do with PEPFAR and the encouragement PEPFAR is given to national systems, as well as the direct inputs of PEPFAR. And more people need to know about that. Thanks for having this session.